Good morning. We're going to get started. So I'm Dipti Chaporia, and I am past president of ACC and a WHF board member, and I'm going to be moderating this wonderful panel, and we're going to be talking about revolutionizing cardiovascular care with innovative care models. I'm sure this is going to be a fantastic panel, and I want to introduce my panelist here. Sitting right here is Dr. Prabhakar Durraj, who's the director of the Center for Chronic Disease Control in India and the Public Health Foundation of India. Next to Dr. Prabhakar is Dr. Demi Edinsab. Did I say your last name right? You can correct me. She is the director of research for the Women's Heart Clinic, Mayo Clinic, Jacksonville. And then next to her is Dr. Lawrence Sperling, cardiologist, executive director of the Million Hearts Program and professor of preventive cardiology, Centers of Disease Control and Prevention here in right from Atlanta. And then next to Dr. Sperling is Professor Yvonne Commodore Mensah. She's a cardiovascular nurse epidemiologist at Johns Hopkins. So you can see why I think this is going to be a wonderful panel. We've got great people on this panel. So as I said, we're going to be talking about cardiovascular care and how to really revolutionize our care. One of the things that I mentioned yesterday at the Future Hub is that in spite of the fact that we have great science in cardiology and we're very technologically savvy, if you think about the last 75 years, and I'm focused on 75 years because we're here to celebrate the 75th anniversary, we really haven't made much progress when it comes to the delivery of cardiovascular care, right? Think about all the great science we have, the great technology we have, but how we fundamentally deliver care hasn't changed. A waiting room still looks the same as it did 75 years ago. So what I'd like to do is, this session is really talking about what are some innovative care models that we can utilize. So let's start with you, Prabhakar. How do you define innovative healthcare approaches, especially in the context of cardiovascular care? And while we do these innovative approaches, how do we maintain patient-centered care while we're incorporating technology? Because we're always afraid that when we get technology in, we're somehow distancing ourselves from the patients.
Thank you, Deepthi, and good morning to everyone. I hope you're able to hear me. Okay, right. So the biggest problem is the definition of innovation. When we define innovation, what most people think about innovation is it's some kind of path-breaking, groundbreaking technological advancement. But it's not really that. Innovation is a disruption from what is happening now to change for something to happen in a new way. You mentioned healthcare. How do we give care to our patients in our outpatients? How do we give care to our patients inpatients and beyond? I mean, when they get discharged, what happens? The other thing is, we have, as you rightly pointed out, we have a lot of evidence. But the problem is that the evidence never gets translated fully. And in many parts of the world, even if you take secondary prevention, for example, where we expect almost 75% risk reduction post myocardial infarction, if you're going to give simple treatments and modify the lifestyle, we are down to around 20% or so. So that's where the innovative approaches lie in terms of improving the care. And I think for any innovation, I mean, we shouldn't conflate innovation to technology, but any innovation or any modification requires 3 or 4 aspects. One, I think a new innovation requires culture sensitivity. We have to address these sensitivities of that particular culture. You might say physical activity is important. For in many parts of the world, women cannot perform physical activity because there's an issue of security. There are lots of other cultural issues. So how do we design something for them? So that's one kind of question that we need to ask. Second is context. What works in one context may not work in another context. And thirdly, it should be acceptable to individuals. So in terms of prevention, for example, innovative approaches include family-based interventions. You cannot advise a patient to modify their diet when the whole family is having a different diet. How do we do that? It becomes difficult. But simple, small, incremental approaches and being moderate and changing a family, the family dynamics can actually improve. And we have shown that in an elegant randomized controlled trial, and that needs scale up. The second thing is health system redesign. We require huge health system redesign in terms of how do we actually improve patient compliance, patient behavior, and also the practices of the healthcare providers. So we are looking at something called consolidated framework, because there are within the health system some barriers, outside the health system barriers. Without understanding those barriers, you cannot actually get into innovations, and that really requires thinking through. And we also need to actually co-design these innovations with all the stakeholders and all the players involved. I'll stop here but come back again later on.
But, we always think about innovation as being so expensive, and you mentioned that there's not always data. But as we do some of this innovative care, and you're very good at talking about frugal innovation, can you talk about that? Because besides data, we need to have the cost alignment, and then that's how we're going to get it to the patients that really need it. Talk to me about some of the programs you've been involved with that.
There are several programs, but I'll just talk about one program. For example, we do what is called as assisted telemedicine. Now, the issue of telemedicine is, world over, telemedicine is actually initiated by the patient. But the patients are not many times not literate and not technologically savvy. In India, we have a large population, so it's an employment generator. So we have created an assisted telemedicine with usually a community health worker or a nurse or somebody else who can provide assistance to these patients by incorporating multiple technologies into the telemedicine platform, making it interoperable. But once we make it interoperable, we can scale it up and make it inexpensive. The second thing that we are looking at in terms of scaling up innovations is use patients themselves. So we are doing a cluster randomized trial of patients who become community champions. They actually mobilize the other patients in the community to modify their lifestyle, to take the treatment that are prescribed regularly, to come to the clinics regularly, get their risk factors assessed, and provide all kinds of support. There are many others that can be done, but I'm just giving you these two examples.
I love the idea of this task shifting. You always talk about that, having community people, patients themselves. So what you're doing is changing the focus from just physician-delivered care to a whole cadre of the cardiovascular team being involved. So tell me the models where you've done this task shifting, how easy is it to shift to these models?
So once you understand what every stakeholder in the whole system thinks, you take a systems approach and the whole system thinks, then it's easy. For example, doctors generally, at least in our part of the world, do not like to use any of these tablets, computers, or mobile phones, because they think that it takes away time from talking to patients. So what we have created is an electronic decision support where a nurse or a community health worker or a pharmacist inputs the data from the patient, and through a machine learning algorithm and AI based system, it provides an output which is a personalized management plan for the patient. It goes to the physician, and the reason why physician is central is because in India, nobody other than a physician can prescribe medicines. So it has to go to the physician. The task becomes very easy for the physician because there's a paper, there's a diagnosis, there is a treatment plan. So the physician can check, confirm whether the diagnosis is right, and actually confirm to have the treatment or not. Everything is printed out, so the time taken is much less for the doctor. Then the patient comes back to the nurse, who provides personalized lifestyle advice based on the decision support. So clearly here we are objectivizing everything rather than leaving things to a subjective element, and we have done trials, we have done demonstration projects and studies and shown that in fact the change in risk factors is very good. In fact, if you look at diabetes control, it's close to 20 to 30 milligram deciliter reduction in fasting blood sugar, which is huge. Systolic blood pressure reduction of 7 millimeters, persisting till around 18 months, which is huge. So these are things that can be done. But moving beyond that, actually we need community engagement, we need patient engagement, we need to talk to them and see how things work. And there are several new methods by which you can assess quality of care. We need to move away from our confirmatory thinking of doing clinical trials or observational studies. How do you assess quality of care? So we have created what is called as e-cohorts, where we give a phone to the patient and the patient tracks over a year's period what happens. They went to the clinic and how they are looking at what was their experience and so on. Also you could do discrete choice experiments, which is a marketing principle. So there are multiple new innovative approaches which are used to evaluate these kind of programs.
So I'm going to move along because I want to make sure that I've got everybody on the panel, and then we're going to leave some time for questions, and then I have more questions from the things that you've said. So you're not off the hook yet. So Demi, you know, one of the things when you look at clinical trials is the fact that there's a lack of women in a lot of these clinical trials. I mean, we've had a push from the United States to include them, and we've had more of an uptake, but we're still not where we believe we should be, right? If the population is 50% women, we should have 50% women in these clinical trials, and we're certainly not getting there. So this has kind of resulted in the significant gap in cardiovascular disease care for women, including the diagnostics, the treatment. So tell me, what innovative health system approach can we deploy to better address and prioritize women's heart health and ensure that we really are recognizing women and effectively integrating them into this whole cardiovascular treatment management?
Thank you for that, Dr. Chaporia. So I would say when it comes to clinical trials and getting women involved, like you mentioned, this is a problem that has been going on for a long time. And even though there has been a lot of efforts, great. The Office of Research for Women's Health, for instance, was developed specifically to address this, and still over time, we're still seeing this huge gap, particularly in cardiovascular clinical trials for women. So I like to look at things from the standpoint of implementation. We always think that implementation science or implementation research is solely for interventions, but we have to start thinking about it from a clinical trial standpoint. We have to understand the context of why women are not getting into clinical trials before saying, oh, we're just not able to enroll them. We need to meet them where they are. So there are specific issues that uniquely affect women. We know there's sex and gender and societal factors that prevent women from being able to get into trials. So an example is that many women tend to be the primary caregiver for their families, either their children or older parents. So they have a lot of caregiving responsibilities, which also makes it difficult for them to come to in-person clinic appointments. And we've already started to see that there's some benefit in telemedicine options for women because of the convenience. So now when it comes to clinical trials, an example of doing something that would meet women where they are is pragmatic, decentralized studies. A lot of these studies require so many frequent visits to the clinical study sites for samples and things like that, and it just does not work well for women. But what if we could take the trials to women? What if we could take these trials to their home? Will we be able to recruit more? And we've already started showing that. There was a large pragmatic study that was done at Mayo Clinic that intended to enroll participants, multiple participants across the United States. And they got good representation of women because it did not require them coming physically to a site to get enrolled to participate in the study. This was something they could do at home. And there's a lot of push and there's a lot of effort now is that we have to take this into account. There was a pilot study that I worked on specifically where we were trying to enroll pregnant and postpartum women. And you can imagine how challenging that is. The stress of having a new baby, the plan of what about the other children that are at home and you want them to come get a test done, or it was really difficult for these women. So we had to think about it. What can we do? Can we provide childcare? Can we provide transportation? So we'll pay for a service like Uber to pick them up and bring them back, make sure that their parking was taken care of, make sure that we're providing remuneration, because these women sometimes have to get a sitter to look after their kids to be able to participate in this trial. So we have to make it easy for women to participate in clinical trials by thinking about the things that are barriers to preventing them from participating in the first place.
I love that, but tell me, it sounds really expensive to design this trial because I have to find money for childcare and now I've got to have money for this and that. Tell me, is there a technological advance that I can use to do data collection? Could my smartphone be good for that?
So that's an excellent question. It sounds like it's more expensive, but it's not, which is where the pragmatic comes into play. A lot of clinical trials are very rigid and regimented in how they want things done. But the pragmatism in these clinical trials is the fact that you're doing things the same way it will be done in a real world setting so that you are not acquiring much more of an expense. And I agree with you, the use of digital tools is also changing how we view clinical trials and how we view studies. a lot of data collection that we could do before now can be done remotely. You don't necessarily have to see that person. We know that with telemedicine, you can even examine patients from home. We have digital stethoscopes that can examine them. You can record heart sounds from remote locations, so you can still get your physical examination findings. Blood pressures can be done with digital devices, smartwatches, so many things that are available to systematically track and collect data that we can incorporate into clinical trials to get the information we need.
So, when you start to use these innovative techniques to try to engage women, what are your parameters for success? Is it that we've actually changed the outcome? Is it that we're successful in terms of the traditional way that we think about? Or is it just the fact that you enroll more women? What's your parameter of success? Or is it all of those?
I think it's all of it, and we have to think about it in different ways. So I was reviewing an article not too long ago, and the article was talking about access to care. And I think that what we're talking about in this context is access to clinical trials and how do we measure it. And they talked about the 5 A's, which sometimes we don't always think about. So first thing is accessibility, which is kind of what I explained. Is this trial accessible to a woman? And these are things I feel like in the development phase, we should think about it thoroughly before we say, let's run this trial. So apart from accessibility, the other thing is affordability. It talks about cost. You just mentioned that. Is it going to be more expensive? And even if we do this trial, we have to think ahead of time. Whatever we're developing, will the patients be able to afford it? Can they get it? Is this something that we can implement and is actually going to be useful? Otherwise, we get all of this science and then we're stuck because then we're not able to translate that into clinical practice. The other thing that they talk about in the A's is acceptability. Is this something that is acceptable? Like someone was telling me about a study that they developed where they were trying to record ECGs, fetal ECGs, and this required actually inserting specific probes intravaginally. Well, that sounds like, something that they can do at the time they go see their doctor and get a transvaginal ultrasound. But just moving forward, it is inconvenient. It's not something that will be a very good uptake for women moving forward. So why even spend all of that time and effort developing a tool like this? Because in advance you haven't thought about, is this something that's going to be acceptable to women moving forward as a good way to screen their baby or test them? So multiple things that we can think about in advance before saying, this is going to be successful, or this is how we're going to track our measures of success for this trial and for women.
Well, again, I've got a lot more questions for you, but I want to move along to Dr. Sperling. And so, Dr. Sperling, you've been the executive director of the Million Hearts, and that's been around for a while, and it's done incredible work. Can you tell us a little bit more about the Million Hearts initiative, and in what ways have you incorporated innovative ways to improve patient health outcomes?
Yeah. Can you hear me? Test, yeah. Thanks. First of all, so wonderful to be serving on this distinguished panel on behalf of WHF and representing our Million Hearts team and the Million Hearts partners across the U.S. This is my home, Atlanta, and this is the 75th anniversary of the ACC. But if you're not aware, the CDC, the Centers for Disease Control and Prevention, is located in Atlanta, and it is also the 75th anniversary of the CDC, coincident with ACC. Million Hearts is a national initiative. It is now 12 and a half years old. This initiative was specifically designed as a co-led initiative between the CDC and CMS, the Center for Medicaid and Medicare Services. The initiative is focused on the fact that we have the knowledge, tools, and resources to prevent at least 1 million heart attacks, strokes, and cardiovascular events in the U.S. within a 5-year cycle. So now we're in the 3rd iteration or cycle of Million Hearts. We call this Million Hearts 2027. We work across all 50 states, and I think a good theme of this session today is Million Hearts is all about partnership. The pillars of Million Hearts are building healthy communities, and so as we think about innovation, and also I love, Prabhakar, the fact that innovation doesn't always mean technology. Innovation could be what we do in Million Hearts, and Million Hearts is implementation science in the real world. So building healthy communities, one of the areas that is very important, and I know WHF sees this as a global priority, is building healthy communities includes focusing on the impact of particle pollution on cardiovascular health. And we know in India now, one of the areas of the world where this is tremendously impactful. We talk about building healthy communities, optimizing care. This is the ABCs, appropriate aspirin use, appropriate, so that's secondary prevention, anticoagulation use for stroke prevention, blood pressure control, cholesterol management, smoking cessation, and then focusing on cardiac rehabilitation. So innovation is, unfortunately, although we can have the next session about AI and all the things everybody's excited about, we do know how to prevent a significant number of cardiovascular events, but we are failing. And so Million Hearts is working through partners, and Million Hearts connects the community to clinicians, hospitals, and health systems, also to population health and public health. And without that greater sphere, we know that in clinical medicine, even when we're providing excellent care, we're only impacting about 20% of the determinants of health or disease. And so if we have our blinders on and we don't embrace our communities and connect with our communities in a trusted manner, we're always going to fall short. So building healthy communities, and the last pillar of Million Hearts is a core focus on health equity. If you want to go to millionhearts.hhs.gov, there are many tools and resources and campaigns that are available, although it's an initiative focused on the U.S. These are tools and resources and campaigns that can be used globally.
So Larry, I love the strategic plan that you guys have for Million Hearts. I mean, it's hard for anybody listening to say that we disagree with anything that you said. But let's talk a little bit more about tactics. So cardiometabolic disease is on the rise. I mean, everywhere you look, and there's a huge interest. And obviously the way that we're going to tackle that is through prevention. So prevention is really getting the shining light that it needs now, because we recognize that no matter what we do, if we don't do prevention well, we're never going to make headway with this. So tell me about what are some of through the experience with Million Hearts, what are some of the effective risk mitigating strategies that you guys have used that has shown a proven record for trying to help out with dealing with cardiometabolic conditions?
Yeah, cardiometabolic conditions are truly a global pandemic. Anywhere from 1/3 to 2/3 of populations are at cardiometabolic risk. We now broaden that. Of course, cardiometabolic risk is a head-to-toe risk, although we talk about kidneys, microvascular disease of the brain, sleep apnea, preeclampsia, gestational diabetes. We can talk about the many conditions that are related to this. It's important we understand that cardiometabolic risk is a risk across the life course. And so cardiometabolic risk may be a risk that starts in utero. And cardiometabolic risk is also a community risk. So as we think about how we approach this, first and foremost, we need to break down silos. We often unintentionally create silos. Here we are at the American College of Cardiology meeting, and there are diabetes meetings, and in clinical care we have diabetes care and cardiology care and liver care and neurology, and even in public health, and I do need to qualify, I'm speaking on behalf of myself today and not representing the federal government, but we have divisions of heart and diabetes and nutrition, physical activity, obesity. So first and foremost, how do we address this? Building healthy communities. Absolutely, this is a disease state that we know, what if we say 1/3 to 2/3 of you will develop breast cancer, but we know how to prevent it. How would we invest in that? It's got to be invested in health approaches at a community level, not an individual level. Not to say, eat better, exercise more, lose weight. Community approaches across the life course, number one. Secondarily, those silos, both with population health, public health, and clinical care. I was in a session yesterday for the ACC where we addressed the importance of togetherness and partnership. And they're building out cardiometabolic clinics where, surprisingly, we're focused on the patient and not the subspecialties. And but truly, if we said climate change, cardiometabolic disease, and then the intersection, we call these converging syndemics. If we learned anything in the 4 years previous, it's that we have very vulnerable populations. Those vulnerable populations have a high level of chronic disease or chronic disease risk. On top of that, we have health inequities all across the nation. Here we are in Atlanta, and we know, I show this slide many places, if you go to the north part of Atlanta called Buckhead, and then you drive 6 miles southwest to Bankhead, 6 mile difference, there is a 10-year difference in life expectancy. We know these inequities play out all across the globe. So we also, in terms of innovation, need to be strategic as we think about health equity that's very different from health equality, because if we invest in a program with the community or a health system or even population health or public health, and we invest in this, across the board, unintentionally we will further the gaps in health inequalities and health inequities. So we need to be very intentional, very strategic as we think about how we are actionable.
I have two questions. The first is, the U.S. healthcare has been very much hospital-based or maybe outpatient-based. We haven't really done very much community-based interventions. What has the experience for Million Hearts been? Is it going, and how easy do you think it's going to be to deploy that model throughout the country?
Yeah, so I frequently describe the healthcare system in our country as fragmented, episodic, and catastrophic. That's never going to be a solution to better health. Million Hearts, one of our main partners, is the National Association of Community Health Centers. In this nation, there are 1,400 community health centers that care for a little less than 1 out of every 10 American lives. Those community health centers, by definition, they're in the community. And those community health centers are part of the community. And to give you an example of what we're doing, and by we, it's not just Million Hearts, it's our partners, we have active projects related to a program called Preventing Heart Attacks and Strokes. Under that project, we have very intentional programs we're working on. Million Hearts is not a descriptive program, it's an actionable program because we want to prevent 1 million heart attacks, strokes, and cardiac events. So we have an initiative focused on improving blood pressure control in Black people. We have an initiative focusing on cholesterol management in those that are high risk and not even receiving, let alone high intensity statin, but a statin with ASCVD, diabetes, LDLs above 190, cardiovascular risk of 20% or greater over 10 years. And then we are trying to magnify the barbershop blood pressure study. Frequently if we say innovation, what are new care models, we can design all the models we want, but I really think the important ingredient is safety and trust. If we do not establish safety and trust, scientifically, we may be very proud of innovative models, but these models will not be able to be delivered. Talking about how we recruit women into clinical trials, how we care for patients, how we build connections to our community, safety and trust is critical if we are going to bridge these gaps.
Now, I appreciate that innovative models doesn't necessarily mean technology, but we know that you mentioned the word access, and access has been an issue for women's health care for lots of underserved populations. Have you piloted any projects where you've actually used technology to overcome that issue?
Absolutely. So an example would be a project we worked on called Hiding in Plain Sight. And you can use this in many different disease states. We used it specifically related to blood pressure and blood pressure control. There are patients that come in and out of health systems every single day with not only uncontrolled hypertension, but what we call here in the southeastern part of the U.S. industrial hypertension, where they're walking in and their blood pressure is 180 over 110 millimeters of mercury, but yet nobody even pays attention because they're coming in and out of health systems with other problems. My elbow hurts. I have a lesion on my skin. I need advice regarding vaccines. So we have the capabilities from a systems approach to sharpen our edge. Now, what do we do with that is very important. So yes, machine learning, algorithms, big data sounds awesome, but we basically flip the problem. So as opposed to that one clinician, one patient conversation, now we can identify these people. How are we going to address this from a system? So we need people, we need teams, we need task shifting, and this doesn't need to be all on our clinicians' back. Our clinicians, at least in this country, are very dedicated and very committed, but time is a very big variable for them. And so how we can make the healthy choice and the healthy step the easy step for the clinician, the patient, and also for our initiatives, those are going to be the winning ventures.
Thank you, Larry. I'm going to move on to Professor Commodore Mencha. And, we talk about the fact health equity has been mentioned by everybody, and health equity has really come to the forefront. So when we're creating or thinking about these innovative care models, how can we conceptualize, and what are some of the key principles that will guide us so that we don't create further inequities in our care?
Absolutely. Thank you all for being here. Such a pleasure to be part of this panel and to contribute to this conversation. So, full disclosure, I am a nurse also, so my perspective really informs how I look at things. And one of the dangers of going last is a lot of the points that I wanted to make have been made by the previous speakers. But in terms of principles, the first I'll say is health equity. I think we all win when we apply a health equity lens, and Dr. Sperling alluded to that earlier. So just understanding that, unfortunately, society's playing field is not level, and there are patients and communities that have to overcome significant challenges. So a health equity first lens, because if we design programs to address maternal health, to address cardiovascular health, and we design it with low-income populations in mind, people who have a disproportionate burden of cardiovascular disease, we all win. So that's one of the first principles. The second is patient and family-centered, and I think Dr. Demi alluded to that earlier. How do we think about what the patient and family prefers? How do we implement shared decision-making? Because we make a lot of assumptions about what our patients need, what they think contributes to cardiovascular disease. And we also know that that encounter, the clinical encounter, is very short. So how do we engage a diverse team? We talked about task shifting, task sharing. I like to use the term team-based care, right? There's a lot of heart disease to go around. How do we engage diverse members of our healthcare team, community health workers, nurses, pharmacists to be part of the team to address patients and families' preferences? And the last one, which I think is absolutely critical, is collaboration. And I think Dr. Sperling has alluded to that as well. I think patients win when we all work well together. And what does that mean? We know that the burden of cardiovascular disease, both locally and globally, is high. So how do we rethink what our current healthcare models look like? And I don't like to use task shifting because it assumes that this is this task, you do it. But how do we work better as teams? And how do we employ these innovations to ensure that we have a greater healthcare workforce to address the burden of cardiovascular disease? And we've had the opportunity to test this in Ghana. So we had a cluster randomized trial where we took nurses and we trained them to manage hypertension We know that in many low and middle income countries, hypertension is a growing public health challenge. So we took 240 patients with uncontrolled hypertension, randomized, and one intervention had nurse-led, technology-enabled, it was a multi-level intervention with home blood pressure monitoring, and this was before COVID. And we gave all participants a home blood pressure device. We gave them a smartphone, and the nurses also had tablets, and they used an app to monitor the patient's blood pressure over time. And in 12 months, 80% of people in the intervention arm had controlled blood pressure. And this was without making any changes to their medications. So just because the patient had direct access and there was bi-directional communication between the nurse and the patient, blood pressure control, the enhanced usual care arm, where we simply send them messages on health, only 20% of participants had their blood pressure controlled. And the beauty of this is we took this model actually from Ghana and we tested it in Baltimore. So when we think about innovations, we like to think about innovations coming from the US, Europe, and taking it to low and middle income countries. And we're really excited that this is one of the clear examples of innovation coming from a low income or low and middle income country to a low resource setting in the US. So that's a clear example of what we call reciprocal innovation. It doesn't always have to happen in one direction.
So, Larry, you mentioned trust. Trust is really important, and the theme from everybody has been community engagement. So I appreciate that. But how do you really engage the community? I mean, if there's an existing community center or workers, that's one thing. But how ultimately are you going to engage a community and empower those community workers? That's a big question.
It's a big question. How much time do we have? So here's the reality. I think it takes time and resources and effort. I'll give a clear example of the Engage with Heart program. This was a Novartis-funded community-based cardiovascular health program. So they gave a grant to the Global Coalition on Aging, and the idea was, how do we co-create a community-based program? So there were co-creation sessions where clinicians, faith-based leaders, the team from Johns Hopkins, we had a local government there, the Maryland Department of Health. So how do we sit together in the same space and create what we think will work best for the community together? How do we share power, right? So that was one of the biggest things, because we were used to power being imbalanced. How do we all come to the table? And when we work together to co-create what this might look like, and then people feel like they're heard, listening, right? Sometimes we don't do a great job of really listening to people to understand what are your needs, because we come to some of this work with, here are all the things we think work. But if we invest that time, and the time part makes a lot of people uncomfortable, because I have a 5-year grant. We need to get working, but sometimes it takes a year to develop and sustain these relationships before you actually start the work.
So, Prabhakar, I'm going to come back to you. I'm really interested in this idea of engaging the community, and you've had a lot of experience doing these community projects. How much work is it really to get those community workers trained and for the community to accept those workers to deliver the care that you want?
I think both pieces are important. How do we train the community workers, and how do we engage the community to accept what the community workers are providing? The training itself is not a very difficult task. Basically, once you have in your mind what exactly has to be done, you can train them. But what is important is for them to consistently perform. So you would want to have a continuous training program. But the more difficult part is, how do we engage the community? I'll give you an example. If you go and ask them about, let's say, what is unhealthy diet, for example, they might find it extremely difficult. But there are new methods. We do what is called as a photo voice method. We ask people to take photographs of things that they think are unhealthy, things that they are healthy, and have a meeting with them and describe. You would be very, it's very, very revealing when we talk to them. So we went to a rural community in south of India in Andhra Pradesh, which is extremely rural community, and told them, look, we asked women, what do you think is a balanced diet? What do you think would you like to feed your children which you think is healthy? But take a photograph and come back. So they took multiple photographs and came back. But consistently every woman showed what we call as a 2-minute noodle, which is very, very popular in India. Nestle makes what is called as Maggi noodles. You just put it in boiling water and you can feed anybody with that. So we said, don't you think this is unhealthy? Don't you think this is unhealthy? So they said, yes, it may be unhealthy, but it's democratic, it's equitable, it's available with everybody, it's very inexpensive. I travel 2 hours to the field to work and then I come back. I need to feed these young kids whatever is available. So you get a different perspective. I mean, you may have a perspective that something is bad or something is good. So here is an example of how you engage the community, and then we ask them, can you devise something which is easier for you? So this is a co-design concept in terms of dietary modification. But even in terms of health system, we ask them about if you are a person with hypertension, what is the most important thing that you would want the clinic to do for you? They said first thing is drugs should be available. The drugs should be freely available for us. It should be consistently available. The second thing is somebody should talk to us. So you take care of these two things, we will come. So there are various ways of handling these innovative methods, not necessarily technology. But as I told you, e-cohorts is a great example. We use this in antenatal care to see whether the women are coming back to the clinic 4 times. Are they being detected to have pregnancy-induced hypertension or gestational diabetes? Is the delivery conducted in a good facility? What is the post-delivery care provided to the women? Are we identifying depression? So actually care improves, because once you take a systems approach and create responsive systems, things improve on their own.
So I'm going to go ahead and ask each of the panel one more question. So I'm hoping that you guys are all thinking about the questions that you want to ask, because I'm going to give you the opportunity. So I'm going to go back to Demi and say, you mentioned about the fact of a lot of women don't want to enroll in trials because of access. But there are other reasons, right? I mean, maybe they're afraid of sometimes the clinical trial design excludes women for different things. What are some of the lessons that you've learned that you need to tackle besides just an access issue?
So that's a great question. And I think that other than access, there's also this thought or prevailing belief that women can be a little bit complicated. So the concern, I was speaking with someone who was trying to enroll participants for a sleep apnea study, and he was like, I've been advised, do not include any pregnant women because we can't figure it out. And I'm like, it's a sleep apnea study. Why are you excluding women? So there are other reasons other than access. Women have been systematically excluded for multiple different reasons, which is why ahead of time, we need to start thinking about what are the reasons, what is the goal, what are we trying to achieve, and can we get data in the right population so that we're designing the study properly. The other thing that I wanted to give an example of, apart from access and getting clinical trials to patients at home, is there are examples where we know that if we focus on women and include them in studies, we can actually affect care specifically for them. So an example is the study that we're working on. We know that artificial intelligence now can be used to analyze data from an ECG and predict the likelihood of cardiac dysfunction. Why is this important? Pregnant and postpartum women here in the US, we know that one of the leading causes of death for them is heart failure, which develops in the last month of pregnancy or in the postpartum period. A big challenge is the fact that heart failure can be difficult to recognize in late pregnant women or in the early postpartum period, because a lot of the physiologic changes of pregnancy are very similar to heart failure symptoms. So it's not unusual for them to complain of lower extremity swelling, shortness of breath with mild exertion, and there's the assumption, oh, you're just pregnant, oh, you just had a baby, it's okay for you to be swollen all over. And these women are missed, and that's why we have poor outcomes. So we need studies that are targeted towards these women. We cannot assume, based on all of our heart failure trials that did not include any pregnant women, that we can use those interventions for this patient population. So we thought, can we leverage technology, something that is newly available, simple tools, safe for mother and baby, to risk stratify pregnant and postpartum women, identify who has heart failure and who needs additional testing. So we did a pilot study here in the US, small sample, caveat, 100 patients, and we showed that this artificial intelligence model, just by recording an ECG, had 100% sensitivity for identifying every single case of cardiomyopathy. So we decided, let's talk about this from a health equity standpoint. Nigeria has the highest reported incidence of peripartum cardiomyopathy, 1 in 100 live births. Mortality rates are very high. 47% of women diagnosed with peripartum cardiomyopathy based on studies coming out of Nigeria. The challenge is also late diagnosis. These women have other responsibilities. They are not able to have multiple contacts with their provider. So we decided to deploy this tool in a randomized clinical trial, pragmatic, when they come to their prenatal care appointments. And we actually presented the results of the baseline from this study when we enrolled women, showing that screening them at the point of care with an artificial intelligence stethoscope that can record an ECG doubled the diagnosis of cardiomyopathy compared to usual care. So huge opportunity for us to influence outcomes and improve care for women.
Wow. Now that's an innovative approach, I will say. Larry, the question I had, hate to come back to cardiometabolic, but it's just there. What do you think about precision medicine? Is that going to be our way to tackle cardiometabolic disease? And if so, how?
Sure, and first I'm just going to comment, we have all this excitement about AI. We absolutely need better HI. That's called human intelligence. And if we are going to address the challenges we have related to cardiometabolic, cardiovascular, and health inequities, we need to continue to think and act in innovative ways, but not necessarily at a high-tech way. So I'm going to create a scenario for all of us. We have two options. Precision medicine, and I'm all for advancing science. We learn a lot through science. An example might be PCSK9. We didn't know that existed 20 years ago, and now not only do we have PCSK9 inhibitors, but maybe we'll have even future ways to address cholesterol management through innovation and science. So we absolutely want to advance science. But here's the scenario. For each of the hospitals you work in, or counties you work in, or countries you serve in, I'll just give you a fixed budget, whether it's, I don't know, $10 million, $100 million, or let's just say $30 billion. And for the next year, you have one of two choices. Are you going to invest in precision medicine or population health? And your goal is to have the greatest impact on the population that trusts you as a whole with bettering their care. Who's investing in precision medicine? Still. Yeah. You won't get results in 1 year. For population health, I see what you're saying. Population health takes time, but I will tell you this. So the Million Hearts Initiative, if we look at the prevention schemata, or what we might call the pyramid of cardiovascular disease prevention, of course, primordial prevention, primary prevention, but if we address it from a population health standpoint, even in a year or 5 years, we also have to understand we have limited dollars, and how we resource those dollars have to be focused on the potential for greatest impact in the shortest periods of time. So the Million Hearts Initiative, if we do the Million Hearts mathematics, we have done this with significant intent to get to 1 million. And that's going to be focusing on those at highest risk, those with established disease, and those at the highest risk for primary prevention. So precision medicine, we will continue to have the conversations. We have biomarkers, we have imaging, we have technology, proteomics, all kinds of things we can focus on, but we need to really use precision medicine to focus on better population health and public health. There's a term called precision population and public health, and that's a way delivering the right care to the right population at the right time as opposed to the right person at the right time.
No, I just wanted to add to what you said about population health. There is a misconception that population health doesn't give immediate results, and I'll just give you two examples. Banning of smoking in public places actually reduced hospital admissions by 17%, and this we thought was just one isolated instance from Helena, Montana. There were 8 other locations where it was analyzed, and it has consistently shown that there's been a reduction of 15 to 17% incidence in myocardial infarction admissions. That's number one. Second is the the COVID pandemic taught us a lot. In Delhi, for example, the average annual PM 2.5, which is a marker of air pollution, is 100. And the WHO says that the annual average has to be 5. So you can imagine in Delhi it's 20 times higher. But in the year of the pandemic, that is 2020, the annual average came down to 40. So you just didn't do anything. There was a lockdown. I'm not saying that lockdown is a solution, but clearly you can get immediate gains through population level interventions. And I'm not discounting the need for precision medicine. It is required because we need to move the needle from illness to wellness. If you have to do that, precision medicine is the answer.
Well, and another example is from England, and Hugh, and you would know this, just in decreasing the amount of salt. Just a small incremental decrease in this amount of salt that was added into foods made a huge difference in terms of hypertension control. And that's something that you can, well, but still, I mean, it you maybe not immediate, but yes. Yvonne, I want to ask you, I don't want to keep coming back to cost, but cost is such an important thing. And even talking all about all this health equity and all the programs we're talking about to prevent inequities, is that going to be expensive?
I'm so glad we're talking about this, and I just want to use this opportunity to say I love what Dr. Demi said about her project, and I feel like it's a great example of local health equity and global health equity, because there's this temptation to think about, well, let's just focus on health equity here, but what she talked about is a great example of an and, right? And so I think it'll be great if there are more opportunities for ACC to partner with WHF to see how do we take some of these examples that are developed locally or globally and learn from each other. So the issue of cost, and I think this is important as we are at this meeting and we're learning of a lot of these novel therapies and medications that are supposed to improve cardiovascular health, how we ensure that the people who need these medicines the most have access to it. We think about some of these obesity medications, and we think about the populations that have a disproportionate burden of obesity. Do they have equitable access? So I think this will really require collaborations between manufacturers, policymakers, all of us. And this is one of my favorite things to talk about, because I think about the sheer number of people that bring trust at this meeting. And I think about how we might have a stronger voice when it comes to advocacy and making sure that all of our patients have access to these innovative therapies. Wouldn't it be just amazing if we didn't think about our roles just in the clinical setting, but as we think about health policies locally and globally, that we are more prominent to ensure that everyone, everywhere has access to these novel therapies?
I want to give the audience an opportunity to ask questions. We got a question back there. Great.
So my question is, how do we meet the needs of an activated patient? Because everything that we have talked about is people who may not have access to care or whatnot. But what I have noticed, at least, is once you have an activated patient who wants a lipoprotein A, ApoB, PLA2 done, our system is not able to meet their needs. But once you have one activated patient, he takes care of all of his social network, and he goes and tells them, hey, I'm actually on a PCSK9 inhibitor, my LDL is down, go see this guy. But we are not able to meet their needs. And for Dr. Prabhakaran, what I can see in India, the social networks are denser. So my parents wanted a coronary artery calcium score, they went and got it done, and they told all of their cousins about it. Now everyone knows their coronary artery calcium score. So how do we meet needs of that activated patient in the US to sort of create similar dense social networks?
So I can't answer for US, but what I can answer for what we are doing in India. So your network of your parents is very different from a rural or a poor network. So what we have done there is identified patients and we have trained them to become a quasi healthcare worker. So they actually build the self-help groups and improve the care of these patients. So we are doing a large cluster randomized trial in India and Nepal to see whether these enlightened patients can be useful in kind of providing that kind of care. But this is a problem because in urban locations we face a similar problem, and there is a limit to how much investigations, how much resources that we can put in. So there's always this law of diminishing returns. As you put higher and higher resources, you will end up in less cost effective choices. Essentially not because it's costly, but actually there can be some small incremental problems that can arise with the patients. So we have to be cognizant of that.
So just to add to that, I think that a great opportunity to leverage social networks in a place like the US is the use of social media. And I think that public health organizations try to leverage this a good amount during the pandemic to battle misinformation, because there was a lot of misinformation going on out there, and it was useful to be able to have communities, trusted groups, information from the CDC or specific health societies about what should we be doing and what should we be following. While it was not perfect in the rollout and how it was done, I think that there is more that we can do with this social media opportunities to provide not just health information, but also guide people towards getting the correct information to improve their health.
Any other questions from the audience? We have a few more minutes. Hewan.
Thanks very much, Dipti. I'm Hewan Gray. I worked in the National Health Service in the UK. I've really enjoyed the discussion. And just a couple of points. One is that my experience in terms of prevention and population health is a real issue when the political timescale is always less than 1 year. You know, trying to get investment when the timescale, the horizon is usually less than 1 year, is really difficult. We're having a discussion at the moment as to how you take it out to 3 years or 5 years. And the second was just a comment about the smoking in public places, which was very effective. But the rationale for that at the time, at least in the UK, was prevention of passive smoking and prevention of longer-term risks associated with passive smoking. It came as slightly surprising that there was such a quick effect on the incidence of myocardial infarction. I mean, great and beneficial, but that wasn't the prime motivation for developing it. A bit like the reduction in air pollution, it's a longer-term timescale that's quite difficult to persuade people to undertake when their timescale is short. So just a comment.
So what I want to do in closing, because we only have a minute, is I want each one of our panelists to give us one takeaway.
One takeaway is what I'm going to take in, I'll take 30 seconds and say, if we require innovations, what are the innovations that, what do we need to do in terms of innovations? I think there are 5 or 6 things. It has to address culture sensitivity. It has to be context specific. It has to be equity promoting. Not only should be inexpensive, but it should be cost effective. It should have a policy dimension so that it becomes scalable and sustainable.
I guess I will take the technological approach to this. If there's one takeaway, I would say is we need to start prioritizing low-risk, high-reward interventions. There's been a lot coming out when it comes to technological solutions, and we're not taking advantage of it. There's a lot of inertia and concerns. Oh, will it help? Or will it drive health disparities? Or will we make things worse? But we can look at the ones that, what are the ones that are likely or less likely to cause harm or risk to that patient, but that we can get big impact from, just like the example of talking about smoking cessation. Even though the goal was not to, like you said, prevent heart attacks, was to prevent a long-term outcome, but we found short-term benefits, and we can start looking at that with technology tools. What is low risk but high reward that we can start to implement right away for our patients?
Yeah, I would add that in terms of innovation, our biggest opportunities are innovation in gaps in implementation. And if we can address those, we have the greatest opportunities to make a difference in the communities we serve, the countries we live in, and around the globe. And we're here as partners today across the world. However we innovate, we cannot innovate and then bring these innovations to populations. We need to listen, we need to communicate, and we need to engage and not only partner with the entities we have here at a meeting like this, but really the key partnerships are with people, families, and communities. And this is the crux of what we need to focus on to better the challenges we have before us.
And I'll just add that my takeaway is that we need to work better as teams. We need everyone, all disciplines, to find a way to work together to promote cardiovascular health. We know that healthcare is a team sport. Soccer is my sport of choice. Yesterday we know there were 50,000 people next door to watch a game. If we want to get this right, everyone has a role to play, and the patients win when we find a way to work together to ensure that we have all the right resources, but everyone has the demarcated role, but we also monitoring and evaluating, but also training our team members. Thank you.
Just so you know, we do this on a more local level when we have things like our ACS meetings in the hospital. We have multidisciplinary teams, and they include community for resources and understanding and population health, and even a patient, if need be, to start understanding where we have to get to on the ground level to make those changes. So all these things that you're doing and talking about, we are trying to make a difference every day. It's really great work. This one.
So I want to thank my panelist, this esteemed panelist, and I want to thank all of you for your attention. Great ideas come from conversations like this, and so I hope that you all, obviously you're here because you're interested in this topic. You learned a lot from the panelists, but we should take these ideas and move them forward and continue to collaborate with each other to make great things happen. So thank you very much.